All right, well, welcome everyone. Thank you for joining us today for our CAI webinar. I'm Nicole, the Continuing Education Coordinator for the Collaborative, and we are thrilled to introduce Carole Hemmelgarn and Sue Sheridan to present today's webinar on the critical role of patient advocacy and transparency in healthcare. Please submit questions into the chat at any time, but we will hold all questions until the end of the presentation, but we'll be monitoring throughout. And with that, not to waste any more time, I'm going to hand it off to Carole.
Thank you, Nicole. Well, welcome. Sue and I are very excited to be here today to talk to you about the critical role of patient advocacy and transparency in healthcare. And when you look at that title, that is a big, vast title, transparency in healthcare. And what we realize is there's so many areas we can touch on. But the scope and framework that we're going to look at today is the role in communication and reconciliation programs, since that's what many of you are interested in. But it's not to say that there aren't many other areas where there's important roles for patients and families in the transparency arena. Sue and I today want to be provocative, because when you're provocative, it makes us all think and reflect, and we're going to make you feel uncomfortable. But that is when change happens. That's when honest conversations also arise, when we're willing to check our own beliefs, values, and systems. So with that being said, I want you today to remove your professional role hat. And I want you to think about this from that of a parent, a spouse, a partner, a sibling, a friend. And when you're thinking of that through those lenses, you're going to think differently about what Sue and I are going to share with you today. Next slide, Nicole. So it's important that you understand where Sue and I come from in this space, because I think context matters to the message that's being delivered. I want to introduce you to my 9-year-old daughter, Alyssa. This is Alyssa Hemmelgarn, and my name is Carole Hemmelgarn. My daughter, Alyssa, died when she was 9 years old of multiple medical errors. I did not choose this path of advocacy. This path was chosen for me. You see, I've worked in healthcare my whole career, and I could not protect and keep my own 9-year-old daughter alive. So when we talk about advocacy, it comes in many different forms. When we are thrust into this work, sometimes it's work we just want to do in our community, the hospital level. Sometimes as we evolve, we want to focus on disease states or things that have happened. And we may even get to the point that we're sitting on boards, we're impacting policy and legislation, we're creating change in payment systems. So again, we start out on one spectrum and we can develop to so many others in this advocacy and transparency space. Next slide, Nicole.
Yeah, this is Sue Sheridan speaking, and this is both my son, Carole Sheridan, and my late husband, Pat. I'm sure many of you know the story that my son suffered permanent brain damage from a series of system failures regarding his newborn jaundice. He's now 27 with significant cerebral palsy and many challenges. My late husband, Pat, died when a tumor was properly diagnosed, but the malignant pathology got lost, and he died when he was 45. Now, since then, my profession was an international trade finance banker. I worked in a very regulated, very, there's a lot of oversight of what we did in banking. And I assumed that the healthcare system was the same. And I learned, much to my horror, that no one really was in charge of patient safety. So it launched me into a career, much like Carole, in patient safety. And through my journey, I've worked as an employee at PCORI, at CMS, at the World Health Organization. And I can honestly say, I got to see within the system how change is taking place and some of the priorities and the discussions. I spent over 10 years of my life in the healthcare system working in it. But I can honestly say that most of the power and most of the learning comes from the patient. And that's what I learned throughout my time at CMS and PCORI. Learn from the wisdom of the patient. And that's what Carole and I are going to talk about.
Next slide, Nicole.
So I want to share a little bit. Carole and I both are co-founders of Patients for Patient Safety US. And we were founded last June. So we are a young organization, but it all started by most of us that you see here have been patient safety activists and advocates sitting on boards and councils and at very high levels for the last 2 decades. And we've really realized that there's been very little impact in patient safety over the years. And matter of fact, we got together in the mountains of McCall, and we all got together to really talk about the drift that we're seeing in patients in our healthcare system, by our government, by our leaders, away from patient safety. We looked at strategies of our government, of NQF, of IHI, of other organizations doing great work, but we've seen that patient safety isn't the focal point like it used to be. So we decided that we would organize under the umbrella of WHO, because while we saw it drifting in the United States, and honestly, it scares us to see this drift, we saw it ramping up around the world at WHO, and they launched this very comprehensive global patient safety action plan, which we've digested and support 100%. So we have formed under the umbrella of WHO's Patients for Patient Safety Global Program to work in partnership with agencies and organizations. We collaborate with CAI, and we collaborate with Ariadne and IHI and the Lucian Leap Institute and AAP, Common Spirit, MedStar, Open Notes, Institute of Safe Medication Practices. We're also actively collaborating with CMS, CDC, NQF, and others to really work together to push the agenda. And so our priorities at PFPS, are one that is a patient-driven agenda, which I think is one of the first patient safety, patient-driven agendas that covers aspects of reporting and transparency and safety of clinical practices, and that we want patient safety as a strategic priority. But something I want to share about PFPS US and our members, not only are we 10 founding members, but we now have over 50 champions and probably over 20 some strategic partners. We're right now working on our value statement. And I can tell you right now that one of our prominent values is about truth telling and transparency. And that's what we're talking about today. So, get to know Patients for Patient Safety on our website. We hope to work with many of you going forward to really provide our nation the impetus to really change patient safety. Next slide.
So Sue sort of set this up. Today, we want to talk about, in the framework of communication and reconciliation programs, the role and advocacy of patients and families. What can we do to make it better, but really address that honesty, transparency, and truth-telling piece. So I went and did a little homework on, what are the definitions? And these all are sort of inextricably linked together. So when you look up honest, it's free of deceit and untruthfulness. And when you look up transparent, it's easy to perceive and detect. But when you look up truth-telling from a medical ethical standpoint, it's the moral duty to be honest with patients. So what we're saying is you can't cherry pick. We talk about cherry picking when you review cases in the CRP concept. You can't kind of be honest, transparent, or truth-telling. Either you are or you aren't. And that's what we want to focus on today is, are your organizations, are they truly honest, transparent, and telling the truth about everything? Or are you picking certain things that you share with patients and families? Next slide, Nicole. So here are the 6 buckets that we're going to talk about today. And many of these align with those of you that know AHRQ's Candor template or your own CRP framework in your organizations. And so I'm going to talk about the top row, and then I'm going to hand it over to Sue to talk about the bottom. And we want questions from you after we discuss this, because we are going to be provocative. We are going to make you think about, what is your organization doing? We want you to challenge us as well on the comments that we're about to make. So we're going to start out, and I'm going to talk about reporting. And Nicole, if you want to just put us full screen, that would be great. So when we talk about reporting, the first thing I want you to think about in your system is most organizations have reporting structures that your employees can report to. But how many of your organizations have a reporting mechanisms that patients and families can report into? And I mean truly designed ways that patients and families can report, not just that, oh, well, they told the nurse something, that a way that they feel empowered. And then do you have a way to educate patients and families about your system so they know how to report into it? We know that we are the 24/7 constant, be it the patient themselves or a loved one in the room. We see it all. We are of value to you in the organization on knowledge that we can share with you the things that we see. Now, oftentimes, when we talk about this, there's this fear that, oh, well, the reporting will be the food was cold, or, I didn't like my bed. We have seen in other types of things implemented, in particular rapid response teams, that years ago when those were rolled out and patients and families could call, there was this fear that they would be called all the time. They would be, minor complaints. Those systems are not used near enough as they should be. That fear that they'll be overused has never come to bear. And it would be the same kind of situation with reporting, but there's good data and information patients and families could share if that mechanism was in place. I know that Tom Gallagher, who is head of the collaborative, was part of a project called We Want to Know. And the beauty of that was it was real time, someone going to patients and families' room, asking them questions about their care. And that has the ability to potentially mitigate downstream harm if we can be proactive and catch potential things up front. So I want you to think about that part of the role and engaging patients and family actually in a system where they have a voice. The second thing I want to address under the reporting bucket is an area that both Sue and I are involved in. And National Jewish Foundation, it has been working for years on creating something similar to the National Transportation Safety Board. When a plane goes down, then that board is enacted right away and everyone goes to the crash site, gathering information. It's a place to report errors. They are in the process of putting a bill forward for a National Patient Safety Board. And this would be that same concept of it's a place where everybody could report. You all and your organizations could report, patients and families could report. It would finally be a big portal with enough information to really look at the big data. And again, how do we mitigate harm? What are the trends we see that we could share across everywhere? Currently, we keep things in our own systems, or they go into a PSO where they stay there and they are never shared. And that wasn't the design of a PSO. It was to be about the learning that went across the organization. So we as patient advocates are really behind this and pushing because, again, when we're harmed, it's about the learning, because we want to make sure what happens to us doesn't happen to anyone else. So the next bucket in my row is event review, event analysis, or what many of you call root cause analysis. I don't call it root cause analysis because rarely is there one root cause. So what is the role in patients and families in the event analysis and review process? It's massive. And if you are not getting the narrative of your patients and families after harm events, once again, you are missing a lot of information that can only make the review complete. You have to have the stories of everyone involved, not just your care team, but the patients and family. And while I've used to be a staunch advocate, and I've changed my ways because I have listened to many of you about making sure that the patient and family is in that review with the provider and care team, I have taken a step back on that because I realize those conversations may not be as open. But how I do think it can be structured is you capture the patient and family narrative part of that piece. You meet with the providers and care team in the structure. You meet as your committee, discuss everything. And then at the end, you come back to the patient and family and you make sure you say, this is what we talked about. This is what we saw. Does it align with what you saw and experienced? Because you need to close that loop, because the patient and family hearing that middle section of that may trigger something else. And they may be like, oh, you're right, plus this. Or nope, I don't agree with that piece because, let's ask my spouse. They were there and that didn't happen. So we need to close that loop. The other piece is you need to have a patient or family member that is a constant person on that event review team analysis. And why do we say this? Because they're the moral compass. They will make sure that they ask those hard questions and that they keep in mind the perspective of the patient and family. And I often hear, well, can someone commit to that? You will have patients and families that commit to that because they believe in the work. And the more they're engaged, the more valuable that they will be to make sure that these event review processes are robust and the patient and family voice stays a major part of it. So the other thing that I want to touch on with the event review process is how is this shared with the rest of the organization? And that's a really big piece as well. And that's, again, where you can use patient and family members. Imagine that when you're talking to other parts of the organization about the events that happen, that you have a patient or family member there being part of that. It shows honesty. It shows transparency. It shows that you're a learning organization and that you value the relationship with patients and families. And again, does this mean taking a risk? Does this mean, it's risk taking. It is risk taking. And I know many of you on here may be in the risk arena, but this is what we need to do if we're going to be truly honest, transparent, and showing truth telling. The last piece that I want to talk about is the communication and harm. And we know, because this is a big focus, that you need to be at the bedside right away having those conversations, and those conversations are ongoing. I cannot tell you how important it is that the conversation doesn't end until the patient or family member says it ends. Because we have to find a place in our heart and our head to put this, and we have to process each one of these steps as we go through it. And sometimes we need to go back. Many of us need to go underground again. We need to rethink, and then we need to come out and ask questions. So what is the role that patients and families play in this? Well, it's a big role. So I can just give you examples of my own experience. Once I was able to get to a place where I could start to engage in the organization where my daughter died, they started to come to me and ask me about certain conversations they were going to have with future patients and families so that they could try to avoid mistakes that were made with me. So examples and advocacy to involve patients and family is one, perhaps you're going to write a letter to a patient or family member because you need to outreach and you want to talk to them about a harm that you encountered. Have you ever looked at the letter through the eyes of a patient or family member? You write it and you think about it, but there are trigger words and there are things in those letters that may set us off. logos from your organization where we were at, certain words like "we understand." So you can start to engage and advocate and have patients and families be involved in this so that they can look at the letter and make sure there's not things that set patients and families off. The other way that more patients and families can help you is practice these conversations. If you're going to be doing a simulation and you've got a big conversation you're going to have, include a patient or family member, because they can say, "Oh no, don't say that," or "You know what, I'm looking at you, and to be honest, I'm feeling like you're cold," or your facial expressions. We viscerally feel things that you can't feel because you've never walked in our shoes. And having us help you there to move this work forward is really important because we see it through a different lens. And unless you've been there, you can't see that. So it's important to start to see the roles and the advocacy opportunities that patients and families can provide. This is also the space where we'll help keep you honest. Are you telling the patient and family everything? You know, if they're going to ask the questions, are you going to answer them truthfully? This is part of that, your organization. You can't kind of be transparent and honest in some parts and not on the other parts. So Sue, I'm going to turn it over to you.
Great. Thanks, Carole. That was fantastic. And to be honest, you know, and Carole knows this, when I was preparing some of my remarks, I also looked up the definition of transparency. And I actually had to text Carole and say, I've come to, after 27 years as a patient activist, I'm wondering if transparency is even the right word. Has it been overused, abused? Is it a way to dance around the word honesty? And so Carole and I both came to the same conclusion. We have to address truth-telling and transparency. Truth-telling is active. It's what we expect. It's an action that the clinicians or the hospitals can take. Transparency is really a process of sharing things. So we don't see one without the other. And we really do focus on truth-telling. And it is one of our values at Patients for Patient Safety. So I'm going to start talking about, in framing this webinar, the reason why transparency in a more global, it's not just telling a patient when things went wrong and apologizing. It's much more of a process, as we know in the CRP, for two reasons, I would say. One, to improve patient safety. Transparency, honesty leads to a safer healthcare system. The second reason for transparency is it's healing. And every step of the way is a healing step for patients. But when there's no transparency, it's additional harm. Like we've talked about, the first harm, which is the actual medical error. The second harm is, but the first harm was unintentional. The second harm, when there's no transparency, is intentional. And so we have an opportunity to look at all these steps as intentional opportunity, or opportunities to intentionally be transparent, to improve our healthcare system, and to contribute to healing. So the first box I'm going to talk about is process improvement. And this is, Carole kind of talked about the transparency part and truth-telling around really figuring out what happened. And my box is about the second thing that patients want is to make sure it won't happen again. We want to know what happened. Number two, it won't happen again. And so I'm really going to talk about this. Let's make sure it doesn't happen again. And, we all know from research that this is really important to patients to know that the healthcare system, both at the local level and the national level, will take every effort to ensure that what happened to your family won't happen to anybody else. If this process is not transparent to us, it is taking away the opportunity for us to heal. And so we believe that, PFPS believes that, we do not support privileged and confidentiality protection to any information that is vital to our healing, our closure, and to improve patient safety. And no, and talking about confidentiality and privileged, when losing a loved one, or having a loved one that's permanently disabled, really think about it. Right now, the privilege and the protection of information about process improvement is the protection of the clinicians in the hospital. Doesn't it seem that when we lose somebody or our baby is permanently disabled, that it's the patient and family who should be privileged and protected? So it seems like our system has lost its focus when they say they're patient-centered. Are you truly patient-centered? So in creating this transparency and truth-telling about process improvement, number one, it makes the healthcare system safer. Number two, it's healing for the patients and family members. I can't imagine a system who would withhold that kind of information from a family. And so, and with CRPs are even suggesting that we're part of creating those process improvements, in healthcare systems. So process improvement should engage us. If we don't want to be engaged, we should be informed of everything that hospital did to prevent it from happening to others. And, I personally could not heal. And I guarantee you that getting a settlement does not satisfy patients. I would not settle in my son's case until I sat down with the board and the CEO to ensure that they implemented a universal bilirubin test to ensure that all babies' bilirubin would be tested so harm wouldn't happen to them. And they did it. And that was probably one of the most healing parts of the whole process, to know that the hospital took those steps. I was part of it and I knew they did it, and they showed me how they did it. And so process improvement should never be undercover. This should be open, transparent, and engage us, all along the way. The second box I'm going to talk about is reporting. Now, we absolutely feel, and it's very natural for a patient, again, along the lines of process improvement, we need to be, and we deserve to be, informed that a death or permanent harm from medical error goes up the ladder to the board, to our state, to our federal regulators, and to our accreditors. Again, why would we hide this and not tell this to patients? And think about the positive aspects of having a policy that informs the family of all the steps that you take outside of in your institution, and then outside of your institution, with those regulatory agencies and oversight bodies who are charged with keeping us safe. And so we believe that, we believe that reporting should be mandatory, PFPS. We've seen the consequences when it's not. And we also believe, frankly, there should be meaningful consequences when there is no reporting to the board, to the state, or to federal agencies. We think beyond the walls of institutions. I think a lot of times when we think CRP or disclosure and process improvement, I think a lot of the healthcare institutions think it's just within your walls that improvement takes place. We patients think way beyond those walls. We think about the other moms and dads in other states and even other countries. And so why can't we spread that learning? And we can't spread that learning without the reporting to our regulatory agencies like CMS, the Joint Commission, and our state health departments. So that is another area of transparency and truth-telling. The last bucket I want to talk about is, it's kind of uncomfortable, but it's, I think most people call it confidentiality clauses. We refer it to as gag clauses, that silences the patient and family member from truth telling. If you really think about who benefits from gagging a patient or family member from telling the truth, talking about their story, it is not the patient. It is the healthcare institution. And patient stories and like Carole and I, we have been telling our stories for me 2 decades, Carole, you for a long time. And, patient stories and our truth telling about what happened, there are abundant pearls of wisdom to improve patient safety. Why would we ever want to silence that? I don't know if many of you have been through a discussion about a gag clause, but from experience, it gives me goosebumps when I talk about it. It is a devastating, heartless conversation and process to get paid off for my silence, which obviously I didn't, because I'm here talking about it. But the interests of the healthcare systems, especially when there's harm and death from care, must never be placed above the interest of the people, namely the patients that they serve. And so, going again, this is about truth-telling, openness, honesty, transparency. Why? To improve healthcare systems and to help us all heal. And, another thing about gag clauses and is that when patients finally sign gag clauses, and a lot of times you're just exhausted and you want to get on with life, you live under a daunting threat for the rest of your life, which I have done. And I've been accused of violating the few things that I agreed to do. And there's this constant cloud over you thinking, gosh, I can't say that. I can't talk about that. In Cal's case, he suffered brain damage from jaundice. When I, opened his case publicly and the Joint Commission got involved and CDC got involved in very positive ways, I learned that there was a whole population of babies before Cal, and I got to meet those mothers who were afraid to speak up because of gag clauses that they had agreed to. So because they couldn't speak up, it was never known that these babies even existed. Had they spoken up, would my son have been harmed? Gag clauses are dangerous. And to be honest, it's another layer of intentional harm to prevent us from speaking about losing our loved ones. It's all I can think of is inhumane. I think, ask yourselves, and I don't know what the practice is nationally. I know it's very widely practiced. I know there have been movements to eliminate gag clauses in healthcare. PFPS US does not support the concept of gag clauses at all because it is unsafe for a healthcare system. So I think that's all I'm going to have you think about. Again, going back to truth-telling, transparency, to heal and to improve our healthcare system.
So you have one last slide, if you want to put that up. And we really want to have a question and answer period with all of you.
Oh, okay. I'm happy. So in closing, what Carole and I are talking about, it's all about the question of will. It is the question of the soul and the courage of healthcare institutions, healthcare workers, our leaders. There's no magic bullet. And so I want you to ask yourselves, after hearing Carole and me, and there's a lot more to discuss about this topic. Ask yourselves, are you using transparency as a tool in your toolkit when it's convenient, like Carole said? Or are you committed to transparency and truth-telling throughout your organization as a value? There's a big difference between using a tool in the toolkit when convenient and a value. And so, of course, PFPS US believes that it is only with transparency and truth-telling by all parties. And that it's an organization value. Will we ever achieve a reduction in harm from unsafe care? So this is really an invitation to all of you to ask yourselves about your values, about your organization. Is transparency just really an illusion in your institution, or are you really embedding the true meaning of transparency and truth-telling? And there's my son Cal, who has communication problems. So he went through school learning how to communicate on his computer, and he did a lot of movie making. And his movie making instructor was kind of a hip, young artist, filmmaker. And I got him a contract with the WHO, and the WHO go around the world. We went around the world and we did all these workshops with patients and providers and administrators all around patient safety, and we'd all get on the same page. And so I would bring back this film from WHO, and the filmmaker would make these very short films for WHO. And he sat back at me and he said, wow, you guys are really tribing up. And I had never heard that term. And what he meant by that, and I've learned about that. And he said, well, teams all have the same goals where tribes have the same values. And so this is coming from the hip language of the young, but I hope we can all tribe up and find, work together around the same values.
Thanks, Sue. So we're intentional about wanting to have a lot of time for discussion, Q&A. If you guys want to put things in the chat and start discussing amongst yourselves, throw out questions, that's the only way we're all going to change this, is to learn from each other. So with that, Nicole, do we have any questions?
We do. We have our first question that came in. It says, I think a lot of the hesitancy for full transparency by health institutions is fear that the efforts we make for transparency in CRP will backfire and will end in a large claim or lengthy lawsuit. Some of the biggest barriers to CRP come not from plaintiffs' attorneys, but from defense counsel. How do you advise increasing buy-in among defense attorneys?
So one of the great things going on with the collaborative right now is we have an attorney alliance, and that is bringing in both the plaintiffs' attorneys, defense attorneys, having these conversations. And in fact, one of the head of this is actually a defense attorney. What we realize, the literature has shown this, and it has borne out with these programs, that there is no, in most cases, because I'm not always, and there's a lot of gray, but in the majority of the CRP work that has gone on, there are not these large claims that come in. And that's because, one, you're catching things earlier. You're getting to the patient and family earlier. You're having the conversations. So I think that, it's been shown it's not there. I think it's just, we get locked in our own perceptions, and those fears and bias sit there, but we're seeing that is not the case.
Let me give you a little different perspective, or an additional perspective. I've heard this argument for 2 decades. We're afraid we'll get sued, therefore we don't want to be honest. Honesty is non-negotiable. There is no profession where honesty should be optional, period. The second thing is, our nation created a legal system for this issue. It is not perfect. It is a patient right to sue. And that is the reality of of the United States. And if a patient's harmed and they need compensation, it will go to it can go to the courts. And we can't remember, this is a civil right in the United States. And so we have a court system, but what's interesting is very few cases end up in court. If you look at the statistics, the David Studdart data, a tiny fraction of those who are truly harmed in the healthcare system end up in court. Yeah. And so I think it's like Carole said, there's a fear, but it's a fear of a system that we have. So instead of taking away the truth from patients, why don't we collectively try to improve that system? Because I can tell you, it needs help. But because of this fear of getting sued, and it's not a good system. Instead of taking away what matters most to us to heal, let's together see how we can improve the tort system and the medical malpractice process.
And I'll just add on to the statistics that Sue was, a study looked at it, and less than 3% of the cases ever go to trial. Now, a lot of it is they go on for years and they're settled right before. 80% of the time, providers win. But the number one takeaway I want y'all to hear when they ask the patients and families why they sue is because they don't know what happened in theirs or their loved one's care. We don't need to go down that road. It is painful for everyone when we could just have these conversations, and it's the moral and ethical thing.
It's the last place we want to be. Believe,
Yeah.
we've been there, and we need to address the system itself, and I would encourage the people in the healthcare system to really recognize that very few patients want to sue. We are not a litigious we are usually taking care of people who have been harmed or dealing with our grief. There's a lot that can be done in their own home, in their own house, to get things in order. We've got a tort system that invites expert witness testimony that is damaging to their profession. And so I think there's a lot of things we could work on together to lessen the likelihood that people would sit in the stand and talk about these huge awards. No patient needs a huge award. We just need to be able to take care of our loved ones.
Nicole, other questions?
We do. We have a couple more questions. Our next question came from Tom Gallagher, and he says, thank you for an outstanding presentation. Have your views on the type of information you would like shared with you to promote healing changed as time has passed since your loved ones were harmed by the healthcare? If so, can you describe the changes in evolution that has occurred?
Do you want to tackle it first?
Sure. I think I got the question. Did the amount of or the kind of information that we got, has that after the harm of our loved ones, has that evolved as time has gone on? Is that?
Have your views on the type of information that you would like shared changed after experiencing the harm? And if so, how have they evolved?
Well, from my, I think everything that Carole and I talked about is that kind of, what if we had all this? I continue to believe that patients should have access to all the information that they want at that time. And I did not get information about how the hospital, well, I finally got information about how the hospitals, both Cal and Pat's, implemented processes. Learning about that was so important, to know that where Pat was harmed, they implemented policies, and they actually named a policy after my husband. And that was healing. And it's nice to know when other agencies address maybe what Carole or, some of the aspects that were important to us. I don't think I'm answering Tom's question, though. At the point of understanding what happened to my family, I can't imagine information I didn't want.
I would agree with that. And since I still don't know what has happened in part of my daughter's care after all these years, I try to tell everyone they ask, there's some of us that want to know everything, and we should be able to hear everything. There are some people that tell you, I want to know these two things, why or where or who or what, whatever it is, because it's the capacity of what people want to know. So the bottom line is, we should be able to ask any question, and we should truthfully be told the answer. And so, Tom, have my views changed? I think since I'm still searching, I can't honestly answer that question because I still don't know a good chunk of what happened with my daughter. So I'm in search of.
Okay, we do have a few more questions. And the first, I think the next is a follow-up on the first question. It says, would it make sense to lobby to change the law so that organizations don't respond with fear and protectionism?
I don't know why we have to have laws, to be honest and truthful. It's the first thing that comes to my mind. When I was thinking about this whole presentation, when we teach our children, those of us that have children, we teach them to be honest, to tell the truth, to say, I'm sorry. I would love to know in life where that changes when we get into the working world and become adults. So, if we have to create legislation, which I know is being created, I know, there's more states that are having sort of this candor laws, which I think is a step in the right direction, because if it helps us get the truth out there and do it quicker and not go to trial and litigation, I think it's great, as long as the patients still get to talk about
Yeah.
what has happened to them? So,
I am a strong supporter of legislation to require honest and open disclosure. 27 years ago, I might have said something else, but I've been a champion of open disclosure and honesty and transparency for 27 years. And especially in light of the current activities around patient safety and the Vanderbilt case and others, I believe we're at the point where we need to legislate. I fear that, and let me say this, I'm not anti-doctor, I married a doctor. But I fear that it has become normalized in healthcare to not be honest. And I don't know how you undo that. Now, if you look at the rest of the world, I mean, the World Health Organization has put out a very robust patient safety plan for the world, and they are calling for patients to advocate for laws for open and honest discussion. And along with that, training and, other, a whole package. If you look at the United Kingdom and Australia, they are required by law to be honest and to openly disclose. And there are penalties if they're not. And so maybe we can learn from some of the other countries who we respect, have very good healthcare systems on how do they do it in a way. And I think they're still learning, but I'm afraid that without legislation, we will not get the honesty and transparency and truth telling that we need to have a safe healthcare system.
I think the only way, Sue, is that the penalty has to be if they lie.
Yeah.
What is that penalty?
Yeah.
To them or the organization that is going to be impactful enough.
Right. And it's unfortunate. I feel for healthcare workers. My best friend's a OBGYN, and I feel for them because we're all stuck in a system that is so terribly broken. And but we've got to really address the areas that are broken, not at the expense of what matters to patients.
Great. Our next comment question comes from Chuck Pilcher. And he says, I contend that NDC's confidentiality clauses kill patients because we doctors cannot learn from the mistakes of others. Thus, the same does happen to someone else. Our legal system has no interest in improving patient safety. What are your thoughts on this?
I agree. I think the current practice of sealing documents and gagging everybody, quite frankly, and I agree that I know that some doctors have been prevented from talking about certain cases, and it probably eats some of them alive as well. And I did not see anything in the healthcare system or during the litigation in my son's case that was pro patient safety, about learning about improving patient safety. It was about winning. And I'll have to share that I lost my son's case and in trial, and the judge threw it out, set aside the verdict, and granted us another trial because of expert witnesses who chose to share untruths. Another, the importance of truth telling. So I agree. I don't think the gag clause serves anybody, but maybe the image and pockets of the healthcare systems. And I mean, I would love to work with providers and other patients on really developing a case against gag clauses for the reason that it prevents learning and healing.
And I think the other thing I'd add to that is, we know what we feel like when we can't talk about it. It would be the same thing for providers.
Yeah.
To not be able to say to a colleague, hey, you don't know the whole story. And I would like to be able to share this, because to help you potentially prevent. Providers are stuck in that same sort of, I don't even want to say defend, but I can't talk about something that is so important. The other thing that this does is I still believe that we will heal better together patients and families and the providers, if they can come together and talk about it. And we have seen this in the case of Teresa and Jack Gentry and some other people out there, where once they were able to talk about it with each other, there was a healing mechanism there, and actually has forged friendships, in some of these situations.
The next comment says, thank you both for this very powerful discussion. We are proud to be a part of your efforts at Patients for Patient Safety US. When we teach organizations about true transparency and CRPs, providers still tell us they have a fear of transparency, of losing their jobs, their license, or worse. The recent Nashville case is an example. How do you advise these providers?
Yeah. Oh, gosh. Well, I think from my point of view, I think providers need to share their expectations of their leaders. I think providers and everybody in healthcare systems need to have that dialogue with their leaders and their expectations that, if they're going to tell the truth, they can't be thrown under the bus. Maybe in the future, we can advocate for legislation that protects, from criminal court, that protects people who come forward and tell the truth. Maybe there's a way to protect, criminal court is not a place to resolve medical errors. I think everybody at PFPS in our community believes that was not the right fit. I think this is really a question of leadership and accountability of organizations. And I think we need to hold the organizations accountable. I don't know if you're aware that PFPS put in an opinion piece last week calling for an investigation of the lack of accountability of Vanderbilt and CMS and the Department of Health of Tennessee. It just focused on the provider, not to exonerate Nurse Fought, but we feel that there has to be more focus on accountability of healthcare systems and their leadership to ensure that providers who step forward are not punished, within that system.
The only thing I'll add is we all have to follow our own moral compass. You have to answer to yourself when you wake up in the morning, when you go to bed at night, as if you feel it's important to have the conversation and you realize you may lose your job over it. That's a conversation you have to have. I can tell you that my job was threatened and impacted when I started coming after the organization where my daughter died. And it was just me, one lone person, but I had to make the decision and have the moral courage in general, to fight and try to get answers. Did they stop me? Did they impede? And, did I have some impacts from my career from that? A little bit, but at least I was able to go to sleep at night.
Nicole, could you ask that person who asked that question, what would they recommend? What do they recommend to make them feel like they can come forward and disclose medical errors? I mean, I would ask this community, what do they see as a solution to that? Or how can we advocate for something that would support that?
The question was submitted anonymously.
Oh, okay.
If that was your question, please feel free to type in the chat or into the Q&A. Your thoughts on that, and I'd be happy to share that with everyone.
I would love to learn from all the people participating. This is kind of our job. At PFPS US, we are willing to tackle uncomfortable issues. We want to advocate for what's right in healthcare, and that's for all of us. So I'd love to hear from the participants.
Yeah, because we would love to support you. If you want to, have a voice against your malpractice care, or we're here. That's what we want to do, because it benefits everyone. That's the end goal.
We don't have a boss.
I know.
I'll keep an eye out for the response.
Yes, exactly.
We have another question from Kathleen Music, and she says, can you discuss the time progression of information sharing? Often in the immediate aftermath of a harm event, the organization and providers don't know what went wrong.
So I'll start with this. You know, Kathleen, we know that the first time just going to the bedside or the phone call, if it's an ambulatory setting, we always focus on the acute, but there's so much other long-term care. Just letting patients and families know about the harm. And we're okay hearing, you know, we don't have all the answers yet. We don't know what has happened. We will find out and we'll keep in touch with you. And the one thing I say is, you know, you tell them, it's like, look, we'll touch base with you in 2 days and we'll call you at 3 and you better call at 3. And then you check in with them and say, all right, when do you want us to get back with you again? As we find out more information, or do you want us to check in 3 days, a week? If you ask us, we will tell you, but we just need to know there's the ongoing communication and we're not abandoned. Because the minute we hear silence is the minute it's like walls are going up, they're not going to tell us. So it's that trusted, ongoing, and we can understand you don't have all the information at that point in time. Just keep giving it to us, and then there may come that point. And again, we know this depends on the level of harm and things going on, that, you know, there's then may be a big discussion as such, especially if it's a sentinel event, or, you know, something that's going to change someone's life forever. So it's just keep the trust, keep the communication.
I agree. Yeah.
Our next comment comes from Armando, and he says, I loved your presentation, and of course, I agree with every single word that you said, but my concern is that we don't have enough resources to disseminate this information to the general public. Can you speak to that comment at all?
You know, I think this might be an Armando that both Beth and I know, or Carole and I know. Yeah. This is always such a challenge, you know, and this is a great question. Something I think we really need to do as an activist group is we need to speak to our national healthcare journalist, and they need to start covering things like this that the general population needs to read about. And I think, you know, and I've been disappointed recently at our healthcare journalist. They also have drifted away from patient safety, and they're more interested in other topics. And so I think our media has a big role to play in informing us about things like this, about transparency, about CRP. I mean, how great would it be if all patients knew when they walked into a hospital that there was something called CRP, and that if something went wrong, we could say CRP. I want to, or candor, you know, candorize. I want to candorize this, whatever. We don't know about it. It's not transparent. And so I know Armando is a big, as we all are, you know, we need to educate the public about how we can get more engaged, but we need that information to come to us. And frankly, our healthcare journalists aren't really doing that. And the patient education materials, there's like no budget for that in our government. There's just very, very little to inform us on how to be more active, proactive patients and partners. So that's a big problem. I'd love to see a budget at HRQ all about not just decision aids, but about information about transparency and CRPs and how to prevent hospital-acquired infections. You know, if we look at the budget, there's very few dollars spent on that. And we need to be engaged in creating that information as well. Yeah.
And I think we have to start a lot of these conversations early, and I mean early in our kids. You know, how do you advocate for yourself? What do you say? You know, I sort of think back on how we brought brushing our teeth and dentistry into the school level. So where do we start that it becomes a norm, that we know this and these conversations take place, that it's just part of the normal way of how we engage healthcare?
All right, well, that brings us right to the top of the hour. I want to thank Sue and Carole for giving us such a wonderful and thought-provoking presentation, and for our participants for being so engaged throughout this time. So thank you all so much. Please look out for the recording on our YouTube channel, and be sure to share it with your colleagues and within your networks. So thank you so much, everyone. Have a wonderful day.
Thank you.